Greetings from Houston. I'm Andrew Civitello. I'm a heart failure specialist at Baylor College of Medicine. I currently have the pleasure of serving as medical director of heart transplantation and mechanical circulatory support at the Texas Heart Institute. When Dr. Inslee first approached me about giving this talk, he very graciously asked me if I had recently given any MCS talks that might fit in with the agenda today. And I let him know that I had recently given a talk entitled Temporary Mechanical Circulatory Support Management Pearls for Our Fellows, and we both tentatively agreed that that might be the talk for me to give to the group today. Now, as I was preparing for the talk and I learned more about your organization and what you were attempting to do, I became concerned that the original talk in its original form was maybe not the best use of our brief amount of time that we had today. In particular, what I don't want to do is provide you with redundant information. The prior talk was full of lots of technical advice that you can easily obtain from device manufacturers like Abiomed and Lenovo and Maricat that all have great technical support groups. And I really don't think that me regurgitating that information is necessarily the best use of our time today. Now, we have a very large and vigorous temporary mechanical support program. This is ECMO data for the last 8 years, showing that we have a very robust ECMO program. I don't have a slide, but I can tell you that our combined Impella and Tandem heart volume is about 2.5 to 3 times our VA ECMO volume. So the point here is not to brag about our volumes. The point is to show that we are a very high volume center. And as a high volume center, we have had ample opportunity to make mistakes. And we have made many mistakes over the past 20 years that I've been here involved in the MCS program. So what I thought I might do today, what I thought might be a better use of our time, is to really discuss some of the lessons that we've learned over the past 20 years. As advertised, I will present some management pearls, but more importantly, I'd like to focus on things that we have learned, and particularly the way that we approach things like device selection and management and policies and procedures that we have implemented to prevent us from making the same mistakes that we've made in the past. I thought I would divide this talk into 3 sections. So first, I'd like to talk about mechanical circulatory support decision making. This really lays the foundation for a successful program and is extremely important. I then want to spend just a few moments on device implantation. We'll talk about some tips and tricks of implantation and how we go about implantation at Baylor St. Luke's Medical Center. And then most importantly, we're going to spend the bulk of the time talking about device management. So, pre-mechanical circulatory device decision making. It's important to remember that these devices are not, in general, therapies for cardiomyopathies. Now, we get into the weeds and we could talk about the potential benefit of unloading for myocardial salvage and acute myocardial infarction, but that's really not our focus here today. Our focus is not revascularization, it is management of cardiogenic shock. And it's important to understand that these devices are just support modalities that allow time for the underlying process to be treated. Now, if I have a patient with a heart transplant that presents with cardiogenic shock due to rejection, putting the patient on temporary MCS gives me time to treat the rejection and potentially allow recovery. On the other hand, if I have a patient, a 25-year-old that presents with a fulminant viral myocarditis, support in time may be all that patient needs, but all the devices do is buy us time. They're not specific treatments. The 3 most important determinants of clinical outcomes with MCS are patient and device selection, patient and device selection, and patient and device selection. So it's really very, very important to get both of those things right. These devices are often labeled as bridges to recovery or bridges to transplantation, but what we want to do at all costs is to avoid building a bridge to nowhere. Therefore, it's extremely important to always have a predefined exit strategy at the time of device implantation. There are really only 4 potential outcomes after temporary MCS device implantation, and we should have some idea of what the expected outcome is at the time of implantation. Most of us would hope for recovery. Unfortunately, that 80-year-old that presents out of the revascularization window with a large anterior wall myocardial infarction is probably not going to recover, and having an exit strategy of recovery for that patient is not realistic. Unfortunately, some of these patients will die. Some will die of progression of disease, some will die of multi-system organ failure, some will have a device complication, and some will appropriately go into palliation. Now, in the patients that don't recover or don't die, the only other two potential outcomes are heart replacement therapy. So orthotopic heart transplantation or left ventricular assist device implantation. Because transplant and LVAD are two of the potential exit strategies that you're likely going to be employing, it's going to be very important for you to closely collaborate with your local heart transplant and LVAD centers, and for each of you to understand these centers' acceptance criteria. Here I've listed some general criteria for heart transplantation, but these criteria are not set in stone, and there may be significant variability in acceptance criteria across various institutions. In particular, things like age, BMI cutoffs, substance abuse policies, these vary widely from program to program. And if you're implanting MCS with an exit strategy of eventual transplantation, it's really important that you know your local program's policy, so you're not promising something to a patient that you ultimately will not be able to deliver. The same holds true with LVAD acceptance criteria, and actually these may vary more across programs. So for instance, patients with renal replacement therapy typically do not do well after LVAD implantation, so it's our center's policy not to implant LVADs in patients receiving renal replacement therapy unless they're going to be a transplant, combined heart and kidney transplant candidate down the road. But again, it's important for you to understand these programmatic policies to avoiding that infamous bridge to nowhere. It's very important to understand that temporary MCS in general has two well-defined goals. On one hand, we're trying to provide circulatory support. We're trying to increase mean arterial pressure, deliver oxygen, and support our vital organs. On the other hand, sometimes we're really focused on ventricular support. We're trying to reduce LV pressure, reduce LV volume, reduce LV myocardial oxygen consumption to hopefully promote LV recovery. And unfortunately, sometimes these two goals are diametrically opposed, and we have to really focus on one or the other because we can't achieve both. When our shock team is activated, these are some of the considerations that we discuss, and we try to do this fairly quickly, but we go through these discussions prior to committing to MCS. Have less invasive therapies been exhausted, right? Have we done everything else up to the point of MCS? We discussed the exit strategy. We always try to predefine an exit strategy before we commit to MCS implantation. We want to know how long do we expect the patient to need support? Is this a stunned heart, or is this chronic heart failure that is now decompensated? The amount of time and support is going to, in part, dictate our device selection and cannulation strategy. If a patient's going to be on support for weeks to months, we're probably going to go for an axillary support so we can mobilize the patient. Do we know the patient's wishes about advanced therapies? That's very important. Patients should not sign a consent for a bypass operation and wake up with an LVAD. Are all the stakeholders involved in decision making? Sometimes it's very difficult to track down that estranged ex-wife who is still the power of attorney. And have we passed the point of no return? Have we really reached futility? And these are all very important discussions. So speaking of futility, you're going to have to make some very hard decisions as a program regarding how much risk that you're willing to accept. And these are very difficult decisions. I mean, imagine from a family standpoint, if you tell them that their father is dying of cardiogenic shock and they have a 10% survival on ECMO, but 100% survival of death without support, families are almost universally going to take that 10% risk of survival. But as a program, you're not going to be viable if you routinely implant temporary MCS with a predicted 90% mortality. So we strongly advocate that you use some sort of objective criteria to help risk stratify these patients and help guide your decision making so that you can use objective data rather than emotion. We're all humans. We want to help everyone that we possibly can, but we also need to protect our programs. The SAVE score has been validated to predict survival after VA ECMO implantation. We routinely use the SAVE score in our decision-making process for ECMO. You can access the risk calculator by typing in save-score.com. It'll take you to the website. You put in some data. It'll give you the SAVE score. You can see here that if your SAVE score is greater than 5, you have a survival to discharge predicted of 75%. If it's -4 to 0, the survival goes down to 42%. If it's -5 or less, your predicted survival is less than 30%. So we start to get very nervous when we get these scores less than 0 and we really have a hard cutoff of a SAVE score -5 or less. So let's say that you've gone through this process, you've developed an exit strategy, and you feel that the patient is a good candidate for temporary mechanical circulatory support. With a plethora of devices that are currently available, including intra-aortic balloon pump counterpulsation, the entire family of Impella catheters, tandem heart, and VA ECMO, how in the world do you decide which is the best device for your given patient? So these are some of the considerations that we use in device selection. So does the patient have isolated LV failure, isolated RV failure, or do they have biventricular failure and need some form of biventricular support? Again, what is the expected duration of support? This is going to go into our cannulation strategies, and if it's going to be a long duration, we really want the patient to be mobile if at all possible. How difficult is it to oxygenate this patient, and are they profoundly hypoxic, and will they need an oxygenator? And if they do, most of these patients are going to get VA ECMO support. Some will get a tandem heart with an oxygenator. We want to discuss end organ perfusion versus myocardial unloading or protection, and I'll talk a little bit more about that in a couple of slides. The technical expertise of the person on call is going to come into play. If you have somebody who's very, very facile with Impella and hasn't done a lot of emergent transeptal punctures, maybe a tandem heart is not the ideal for that particular patient and that particular provider. And then institutional experience and what is available in your particular hospital at a particular time, right? So are you going to implant this device at bedside? Do you have support to do that? Is there a cath lab available? Do you have a hybrid OR available? All these things take part of our decision making when we're talking about device selection. Let's take a minute to go back to those two goals of mechanical circulatory support that we talked about, systemic perfusion and myocardial protection, and let's look at the differential effect that the various device has on those two parameters. This is a series of pressure volume loops showing the hemodynamics effects of various MCS devices, and one thing that we can see here quite clearly is that we go from baseline to VA ECMO support, that the LVEDP goes up significantly. However, if we go from baseline to Impella support, Impella 5.0 support, we can see that the LVEDP decreases significantly with Impella support. So there's already a differential. Let's take a closer look at Impella versus ECMO with regards to myocardial oxygen consumption. So as you remember, myocardial oxygen demand is directly related to the pressure volume area, which is the area circumscribed by the end systolic pressure volume relationship, the end diastolic pressure volume relationship, and the systolic portion of the pressure volume loop, which is the red and blue combined in the diagrams above. You can see that the energy expenditure is decreased from baseline with Impella support and increased from baseline with VA ECMO support. This becomes very important for device selection. If we're focused on myocardial recovery, then Impella support may be our best choice as it decreases myocardial oxygen consumption and promotes recovery. Conversely, if we're focused on systemic perfusion or need biventricular support, VA ECMO may be a better choice. Here I've summarized the hemodynamic support versus myocardial protection for inotropes and the available temporary MCS devices. On the left, you can see that VA ECMO, Tandem Heart, and the Impella 5.0 and 5.5 devices all provide nearly equivalent hemodynamic support in isolated LV failure. However, on the right, you can see that myocardial protection is superior with Tandem Heart and Impella compared to VA ECMO, inotropes, and balloon pump. So how do we put all this together? So this is a condensed version of the algorithm that we use for device selection. If the patient is in active cardiac arrest with CPR in progress, then in selected patients, we're going to proceed with VA ECMO support. The next question that we're going to ask if they're not in cardiac arrest is, what is the respiratory status, and are we able to oxygenate this patient? And if not, we would again proceed to VA ECMO, so we can have an oxygenator in place, or in select cases, a Tandem Heart with an oxygenator. And then finally, we want to know if the patient is in isolated left ventricular failure, biventricular failure, or isolated right ventricular failure. And note in the middle that we're using a combination of invasive hemodynamic and echocardiographic data to make that determination. A patient that has isolated left ventricular failure will then have an LV PVAD. Patient with biventricular failure will either get combined temporary left and right-sided support or via ECMO, and a patient with isolated RV failure can be supported with either a percutaneous RVAD or with VA ECMO. So it's important to note that the invasive hemodynamic data is really required for optimal device selection. And unless there's an extreme emergency, i.e. CPR in progress, requiring bedside cannulation, we always want to perform a right heart catheterization to guide MCS device selection. Invasive hemodynamics and PA catheters are extremely important, not only for device selection, but ultimately for device management. And there's pretty strong emerging data suggesting that routine use of PA catheters to guide management and cardiogenic shock improves mortality. So what lessons have we learned with regards to pre-implant decision making? Well, number one, we need to always have a predefined exit strategy. We do not want to be building bridges to nowhere. Number two, I highly recommend that you become familiar with your local heart transplant and LVAD acceptance criteria. Again, we don't want to be making promises to patients and families that ultimately don't come to fruition because we're not familiar with those acceptance criteria. Number three, invasive hemodynamic data is required to guide optimal device selection, and we use PA catheters whenever possible, unless there's CPR in progress, and even if there is, we're going to put a PA catheter in later when things settle down. And number four, I really recommend that you develop program-specific exclusion criteria. Use whatever objective criteria that you think is reasonable. You're going to have to ultimately assess what your risk acceptance and risk aversion is. But once you make those exclusion criteria, you want to develop some hard stops, and you want to enforce those hard stops.